Our next section is congestive heart failure. Now, congestive heart failure is the most common reason to be admitted to the hospital in the United States of America. And the term congestive heart failure can be applied to either systolic or diastolic dysfunction. It has a standard set of diagnostic tests of echo, occasionally catheterization, and there are a number of treatments which all distinctly lower mortality. All forms of congestive heart failure or cardiomyopathy all result in shortness of breath or dyspnea. Every single one of these can result in a decreased forward flow of blood, whether it's from systolic or diastolic dysfunction. You cannot tell based on those symptoms because the systolic dysfunction or diastolic dysfunction, whether I can contract but can't relax, I can relax but can't contract, the symptoms for the patient are the same, which is a sense of breathlessness, of insufficient oxygen delivery, particularly as you exercise. If the fluid builds up in the lungs, it does not matter whether it's from systolic or diastolic dysfunction because blood does not move forward and doesn't feed the tissues. And the only way to be able to tell is it systolic dysfunction with a low ejection fraction and cardiac dilation, or is it diastolic dysfunction with a preserved ejection fraction? You like that? It's not exactly high, it just hasn't gone down. The only way that you can distinguish these is by the echocardiogram. You cannot tell based on the symptoms whether it is systolic versus diastolic dysfunction. And the reason why this is indispensably important is because the treatments are considerably different. The most common cause of congestive heart failure is hypertension, leading to diastolic dysfunction. Now, people who have a myocardial infarction can develop congestive failure much more rapidly because they kill off part of the heart with an infarction. And you can have an infarction at 9 o'clock in the morning, and by 9:15 have systolic dysfunction. But there are far more people with hypertension where you initially have preservation of ejection fraction and diastolic dysfunction, but over time it starts to dilate up. That's simply much more common than people who have myocardial infarctions. But valvular heart disease of any type, whether it's regurgitant or stenotic, can result in congestive failure. Because whether you have the blood that leaks backwards or blood that's obstructed from going forward feels the same to the heart and to the person's symptoms. The overall mortality from myocardial infarction is considerably decreased. 40 years ago, the mortality from an anterior wall myocardial infarction was 20 to 40%. Thrombolytics and angioplasty decrease it by 25%, relative risk reduction. Aspirin by 25%, beta blockers 10, 20, 30%, ACE inhibitors another 10 or 20%, statins another 10%. Well, when you get through with all these reductions in mortality, where are all the people? Well, in fact, 3/4 of the people who used to die aren't dead at all. Some are normal and some are living with congestive heart failure. Dead or infarcted heart does not pump. Now, many of those patients who had myocardial infarctions were saved from having any diastolic or systolic dysfunction, and others who would certainly have been dead are simply alive now living with congestive heart failure. This is why it's such a common cause of being admitted to the hospital in the United States. It's the most common cause. And as the death rate goes down from these medications, the living with congestive heart failure rate goes up. And this will continue to happen as we improve our therapy of a myocardial infarction. Many are normal, and the rest are living with congestive heart failure. When you infarct and the tissue dies, it dilates. And as you dilate, automatically the lesions start to separate the valve leaflets and you must regurgitate. Infarction makes you dilate. Dilate makes you regurgitate. No one infarcts their heart and gets a shorter, tighter, more efficient heart. Infarction automatically must lead to dilation and regurgitation. No one becomes more efficient as they become dead. That'd be like saying he had a stroke and he became an Olympic athlete. That doesn't happen. That is why automatically infarction dilates, regurgitates, and leads to congestive heart failure. Now, although the symptoms may be the same, you can't tell from symptoms of shortness of breath, edema, orthopnea, where I get more short of breath lying flat. You can't tell just by those symptoms whether it's from ischemia or hypertension or from alcohol. You'd have to exclude coronary disease and see alcohol in the history. We stressed you and we did catheterization, and there's no coronary disease, but there's a lot of alcohol in your history. You had viral myocarditis. That's a lot of idiopathic dilated cardiomyopathies. People had viral myocarditis they didn't even know about. And then you say, why are you so short of breath? I don't know. The person has dilated cardiomyopathy. You stress them, it's negative. You cath them, it's negative. You can't find anything in their coronary arteries, but they have a dilated cardiomyopathy. Oh, you must be a big drinker. No, I'm a Mormon. I don't drink at all. Undiagnosed viral myocarditis. Because radiation, you'll have that stick out in your history. It's not like some guy says, wow, is that what that machine was, shooting invisible beams of radiation at me? No, you know you had radiation. You know you had adriamycin, doxorubicin use. Chagas disease, well, this is the US MLE. If this was Brazilian medical MLE, then maybe it would be Chagas disease. But Chagas doesn't present with chest pain. It presents with a dilated cardiomyopathy. Hemochromatosis can do both, as the iron infiltrates the muscle, damages the muscle, and we can also have restrictive cardiomyopathy. Thyroid disease, whether hyper or hypo, you get a myopathy from thyroid disease. Myopathy everywhere. Your muscles simply do not work well with thyroid dysfunction. We do not know why people have antibodies attacking their heart and peripartum cardiomyopathy. They do. A small number of people have an allergy against their own heart. Thiamine deficiency is more traditional, wet beriberi, amazingly uncommon. But all of these, probably with the exception of hemochromatosis, where there's actually tests of high iron, low iron binding capacity, high iron, low iron binding capacity, high iron, low iron binding capacity, high ferritin, 282Y mutation. Why do you have hemochromatosis? I don't know, 282Y. With the exception of hemochromatosis, there really aren't any diagnostic tests that really confirm it. An endomyocardial biopsy, although it is the most accurate test of them, is rarely, if ever, done. Ischemia and hypertension are by far the more common causes. If you take everything in this list, add it up together, and multiply it by 10, it's not as common as hypertension and ischemia. But you must know them because the management of dilated cardiomyopathy from all of these disorders and the management of post-myocardial infarction cardiomyopathy is exactly the same, except for one thing: revascularization. You cannot revascularize out of alcoholism. You cannot bypass alcoholism. There's no way of getting around it. It's all in the history, however. Knowing the presentation is so you can answer the question, what's the most likely diagnosis? There's a lot of reasons to have shortness of breath, but those reasons, such as pulmonary emboli and pneumonia, don't give you orthopnea. Orthopnea is the positionality of shortness of breath. This is one of the most unique features of congestive heart failure. As you lie flat, blood pools in your lungs. You see, there are a lot of reasons to have edema. You could have low albumin. You could have an obstruction. There are a lot of reasons to have RALS even. You could have RALS from congestive failure, but you could have RALS from people who simply have pneumonia, crepitations, jugular venous distension, constrictive pericarditis could do that. But orthopnea, the positionality of things, that's truly unique. Paroxysmal nocturnal dyspnea is extreme pooling of the blood in your lungs at night. It gets worse at night. And S3 gallop, with the exception of healthy young athletic people, extra fluid building up in your heart. Rapid ventricular filling is quite characteristic of only congestive failure. And remember, you could definitely be asked to listen to a congestive failure heart sound or breath sound, and especially to identify S3 gallop. It's a real auscultatory findings. It's not one just for examinations. It's real. You'll see it. And you can be played it. And you have to be ready. Here's some of the auscultatory findings in the cardiac cycle as you go from P, QRS, and T. I know it looks like a wide QRS, but it's not supposed to be doing that. We're just slowing it down. So the first thing is S4 gallop. Now, an S4 gallop is the sound of atrial systole into a stiff, non-compliant ventricle. Atrial systole into a stiff or non-compliant ventricle. Your atrium contracts and your ventricle relaxes and receives the blood. Not a problem. It doesn't make a sound. It's soundless because your heart is not stiff and non-compliant. But when you have hypertrophic cardiomyopathy, when you have a person who's got hypertension, S4 gallop is a sign of hypertrophic cardiomyopathy, of hypertension. You don't have to add the therapy. You don't have to do anything extra. You don't need anything acute. You just treat the hypertension. Now, in S3 gallop is different. That's when the mitral valve opens. The mitral valve opens and there's very rapid filling of that ventricle. It's like a big splash, like a waterfall, because all that blood's built up back there from the lungs and the atrium, and the mitral valve opens and splashes. Niagara Falls come into that left ventricle. Now, S3 gallop must get therapy. S3 gallop gets more diuretics. S3 gallop gets more treatment. S4 gallop, you are going to treat the hypertension anyway. You don't have to add anything. But S3 gallop is a disaster. You should not leave somebody walking around with an S3 gallop. Anybody with an S3 gallop implies severe illness. S4 gallop can just happen. S3 gallop, fluid overload, much worse disease with an S3 gallop. Remember, the most frequently asked question on Step 2 CK is, what's the most likely diagnosis? So how do I answer the question, what's the most likely diagnosis for shortness of breath? It's sudden onset. The lungs are clear. Which of the following is the most likely diagnosis? Sudden onset of shortness of breath and clear lungs. Sudden onset of shortness of breath and clear lungs equals pulmonary embolus. What's the most likely diagnosis? It's sudden onset, wheezing, and increased expiratory phase. Most likely diagnosis is asthma. There, that's to make you feel good. Feel good? Yeah, I knew one. Oh, it's slower. Fever, cough, and sputum, and pneumonia. Now, decreased breath sounds on one side with tracheal deviation. The most likely diagnosis is pneumothorax. Get a chest x-ray. Put a needle in the chest tube, pneumothorax. The most common question on Step 2 USMLE is, what is the most likely diagnosis? So in this case, for shortness of breath, the key feature is circumoral numbness, caffeine use, or history of anxiety. If you see those things in the history, the most likely diagnosis is a panic attack. Circumoral numbness happens because as you hyperventilate, it increases the binding of free calcium to albumin. When you lower the calcium level in the blood, lower the level of free calcium, that provokes a premature depolarization of the neural tissue. It makes you numb around your mouth. It's characteristic. When they're pale and it's gradual and slow, that's sounding awfully anemia-like. I'm tired. Pulsus paradoxus, which is a decrease in blood pressure of greater than 10 millimeters of mercury on inhalation. That pulsus paradoxus, a decrease in blood pressure with decreased heart sounds in JVD, that is tamponade. And palpitations and syncope are consistent, well, pretty much arrhythmia of any kind, because most of these other things shouldn't actually make you pass out, but arrhythmia definitely will. Sudden loss, sudden regaining of consciousness, syncope from arrhythmia of almost any kind that is in the ventricle. Now, when you see dullness to percussion at the bases, and you have a massive pleural effusion, any pleural effusion that's so bad, so severe that actually impairs breathing has to be drained out. What's the indication for the chest tube? Pleural effusion impairing breathing. Ooh, long smoking history, but besides that, the barrel chest is people have COPD and emphysema. And if you have some Brown blood. Now, this is the only hard one. This is a really hard one here. When basically brown blood, anesthetic use, and it doesn't get better with oxygen. It's been oxidized. It's been like iron. It's like rusty. It's brown because it's been turned into the oxygenated state. Won't pick up any. So the iron is oxidized, but it won't pick up oxygen. What about the paradox of that? That is methemoglobinemia. When you have blood iron, the hemoglobin has been turned into a 3+ state. Ferrous, isn't it? And doesn't allow you to pick up oxygen and turn brown. To get treated with methylene blue. Methylene blue. Look for the recent anesthetic use. Ooh, burning, combustion, wood burning stoves, suicide attempt, and the blood is red, and the blood is red, and the blood is red. Carbon monoxide poisoning. And the indication when you get that shorter breath is 100% oxygen and hyperbaric oxygen. Hyperbaric, when there's CNS, cardiac, or metabolic acidosis, hyperbaric oxygen. The key issue to the diagnosis, however, is all the things I just described are not going to have orthopnea or paroxysmal nocturnal dyspnea. They're not going to have positionality where blood pools in their lungs. They're not going to have an S3 gallop, which is a sign of fluid overload. They're not going to have that because they're not from fluid overload. The key to the diagnosis of all forms of congestive heart failure is the echocardiogram. It is clearly the most important test in congestive heart failure. Now, it's not necessarily the single most accurate test for ejection fraction, but is what we use 99.9% of the time. Transthoracic echo is first. There is simply no other way to distinguish systolic versus diastolic dysfunction without the echo. Simply no way to distinguish them without the echo. Ding, 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 ding. High yield! It will not distinguish by history or physical or the other tests like an EKG or even a BNP, brain natriuretic peptide. That's atrial natriuretic peptide. It's a very difficult word. BNP, which is atrial natriuretic peptide, is a test that you do in acute settings when you're not certain about the diagnosis. The BNP is up in CHF, but more important than that, when it's normal, it excludes CHF as the cause of someone's shortness of breath. That's the most important thing about BNP, brain natriuretic peptide, is to distinguish other forms of shortness of breath from congestive failure. But they can't tell you the type of congestive failure without the echo. Echo is mandatory for every person with congestive failure, period. Now, the best initial one of these tests is the transthoracic echo. The transthoracic echo is a fine test for looking at ejection fraction, wall motion, ejection fraction. Now, it's not the most accurate. The most accurate test of ejection fraction. Now, this is one of those questions where you're going to have to answer something that you've never seen done. The most accurate test of ejection fraction. I didn't say we do it, but the single most precise method is the MUGA scan, or nuclear ventriculogram. That is the single most precise method of looking at ejection fraction. A multi-gated scan. You inject a nuclear isotope and see how much is ejected from it. The difference between you inject it into the bloodstream and see how much of that nuclear isotope is ejected from the heart. You inject and then watch how much is ejected and subtract what's an end diastole from systole. End diastole and systole. And you get an exact percentage. So this way you say, well, rather than taking a two-dimensional image, I'm actually looking at the amount of nuclear energy emitted from the heart. Wow. This would be like somebody who needs to have super precise measurements, such as, hey, you've got lymphoma. Oh, man, that sucks. I better give you a lot of chemotherapy to cure it. Yeah, but if you give me too much chemo, you're going to kill me with the adriamycin cardiac toxicity. Yeah, but if I don't give you enough, I'm not going to cure your lymphoma. Well, I better be sure I give you as much as I can without damaging your heart. MUGA scan or nuclear ventriculogram. Transesophageal echo is good for valves. but not necessary for ejection fraction. We don't have to do the transesophageal echo just for ejection fraction. And you see, what's difficult about being a medical school student on this is without an experiential base, it's hard to relate to the fact that a transducer down your throat and the complexity of that is really, it's more difficult than you might think. So transthoracic first. MUGA is best, and transesophageal echo is to look for valve function. You don't need it for wall motion. So remember, the nuclear ventriculogram. I'm saying this again because it's a foreign concept for people that haven't thought about it. It is the most accurate. It is rarely needed. It would be used to be able to be sure that you didn't give too much chemotherapy and tried to get the maximum dose, but not cause cardiomyopathy. Tough subject for people. The BNP is a difficult term because remember, it's atrial natriuretic peptide. A person's in the emergency room and they're short of breath. Why? You can't wait for the echo. You can't tell. Is it a pulmonary embolus? Is it pneumonia? Is it a pulmonary embolus? Is it pneumonia? Is it COPD? Is it a pulmonary embolus? Is it pneumonia? Is it COPD? Is it congestive failure? Often the chest x-ray can't tell. Sometimes the chest x-ray can't tell. A normal BNP excludes congestive failure. That's what it's for. Normal one excludes CHF. Goes up from atrial stretch. Because so much of step 2, we work backwards from when is this test the answer? When is this treatment the answer? We want to be able to work backwards from the test and say, EKG. Well, EKG in a person who has congestive failure is so indispensably important because you don't know if the myocardial infarction got you there or heart block is contributing. The same way in a chest x-ray, although you can't tell the precise etiology, you can tell whether you have a dilated cardiomyopathy or not. And the Holter monitor is particularly important when somebody has an acute exacerbation of CHF. Why did you get suddenly short of breath? Did you have an arrhythmia? See, acute exacerbations of CHF don't just happen for no reason. Ischemia, arrhythmia, infection, noncompliance. Ischemia, did your heart get ischemic? Because that's why it's not beating so well. Arrhythmia, well, normally the atrial contribution is about 10 or 15% of cardiac output. But if you have a sick, leaky, weak heart, now maybe that atrium is contributing 30 or 40%, and you lose it with atrial fibrillation, and maybe that's why you have flash pulmonary edema. Cardiac catheterization is not necessary too often, but it does tell you precise valve diameters and defects and valve gradients and pressures to determine the etiology. A CBC is important because anemia can provoke shortness of breath. See, if you don't have any hemoglobin, you can't carry oxygen. And if you can't carry oxygen, you're going to feel short of breath. Period. So what possible relationship could thyroid function tests have with congestive heart failure? And that answer is because both high and low thyroid levels cause cardiomyopathy. A myocardial biopsy, although it may be the most accurate test of things like sarcoid, amyloid, hemochromatosis, they are rarely needed. Rarely needed. A busy hospital in New York City can do 1 or 2 a year. So it's rarely needed. And we can biopsy other sites rather than have to take a piece of the heart itself. The Swan-Ganz catheter is not routinely done. It is not routinely done in anyone anymore. But if we have a person who's got congestive failure, but they also have ARDS, and maybe they have pneumonia, and we just can't read that x-ray, we can use a Swan-Ganz because we know that a normal wedge pressure means it's not congestive failure. That's where the Swan-Ganz catheter, the right heart catheter, can be very useful because it helps us to understand that a normal wedge pressure effectively excludes congestive heart failure as the cause of the shortness of breath. The most frequently tested portion of congestive heart failure. Which drugs are essential for systolic dysfunction? ACE inhibitors or ARBs as afterload reduction are unquestionably the mainstay of therapy for every systolic dysfunction. Not every beta blocker, but carvedilol, metoprolol, bisoprolol, carvedilol, metoprolol, bisoprolol as the beta blockers that have the greatest benefit in systolic dysfunction. Spironolactone and eplerenone. Spironolactone causes gynecomastia. So eplerenone has the effect of decreasing mortality. It is an aldosterone antagonist, and the most common misunderstanding is that spironolactone is not given as a diuretic. This is very hard for students to understand because in your step 1 part of your brain, you've got it classified under potassium-sparing diuretics. It's that way in books. It's that way in pharmacology classes. Yet it's not used as a diuretic. With the exception of cirrhotic patients, it's not used as a diuretic. It's used because it's an aldosterone antagonist. And as an aldosterone antagonist, it lowers mortality and can cause hyperkalemia. Diuretics are used to decrease fluid overload symptoms, but diuretics don't decrease mortality and they don't decrease aldosterone. Matter of fact, they increase aldosterone. Digoxin has been used for 225 years. In that entire time, has not been shown to lower mortality in congestive failure. It is used in systolic dysfunction for one very specific purpose. It decreases symptoms and decreases the frequency of hospitalization. ACE and ARBs for all systolic dysfunction. However, ACE inhibitors, angiotensin-converting enzyme inhibitors, are always first. This is a very clear question. It's not my opinion. You don't have to believe me. You just have to answer it. If there's a choice, it's ACE inhibitors first. All stages of disease with congestive heart failure, with systolic dysfunction. And all drugs in the class have the benefit. Now, the only difference between captopril, lisinopril, and allopril and all the other prils is simply the dosing. And since step 2 doesn't test dosing, it doesn't matter which one you use. ARBs are the best next step when you develop that cough. Just remember, you can't use ARBs if the reason for discontinuing the ACE inhibitor is hyperkalemia, since the ARBs also cause hyperkalemia. When is combination therapy, ACE and ARBs together, the answer? Never. No combinations for ACE and ARBs. Nice idea, just doesn't help. The benefit of beta blockers is not from all the drugs in the class. Now, beta blockers for a long time were considered to be contraindicated in congestive failure. We now know that beta blockers are one of the best drugs for lowering mortality. Not all of them, certainly not propranolol, but for metoprolol, bisoprolol, carvedilol, metoprolol, bisoprolol, carvedilol. Carvedilol is a non-specific beta and a central-acting alpha. It's a non-specific beta and a central-acting alpha. It's one of the few times we will use a non-specific beta blocker, but again, it's not a pure beta blocker. It's mixed with central-acting alpha effect. Now, the reason that beta blockers lower mortality is complicated. It's because they're anti-ischemic as well. This is very complicated because even though they're negative inotropes, they lower mortality when your ejection fraction is low. Isn't that paradoxical? And they lower mortality, the beta blockers, because we forget, if we ever knew, how do you die of congestive failure? You don't die of fluid overload. You don't die of acute pulmonary edema. You die of congestive failure from ischemia-mediated arrhythmia, from sudden death in the middle of the night, and you never know why they died. Beta blockers are antiarrhythmic. Beta blockers are anti-ischemic. And when you decrease the heart rate, you decrease the oxygen consumption. And when you decrease the oxygen consumption, you decrease the rate of arrhythmias. You decrease the demand and increase the supply. Wow. What's the most common cause of death from congestive heart failure? The answer is arrhythmia leading to sudden death. It is not pulmonary edema. If you come in with pulmonary edema, we can fix you. We can give you a furosemide as a diuretic, or ethacrynic acid, or bumetanide, and if we can't do that, we can put you in a microwave oven and dry you out. Myocardial infarction is just not how you die. We have myocardial infarctions causing congestive failure, but congestive failure causing myocardial infarction is not too common. We have ischemia causing acute pulmonary edema, but pulmonary edema is not too common a cause of ischemia. The CHF doesn't cause the MI. The MI caused the CHF exacerbation, the pulmonary emboli. Clots are rare in congestive failure unless there's atrial fibrillation. And myocardial rupture is a complication of acute myocardial infarction. With the rupture, it's not from CHF. The most common cause of death from congestive heart failure is ischemia-mediated arrhythmia. That's why beta blockers are so beneficial. They're antiarrhythmic and anti-ischemic. Spironolactone derives its benefit from being an antagonist of aldosterone. Because it's an antagonist of aldosterone, you can get hyperkalemia, but it lowers mortality in advanced class CHF. Now, I'm not a big fan of making people memorize the different classes, mostly because it's just common sense. Class 1 is only with very severe exertion, and Class 2 is a little more, and Class 4 is almost everybody that gets admitted to the hospital, which is shortness of breath at rest. So I'm not a big fan of making them memorize the classes. And besides that, almost all the ones that you've ever seen admitted to the hospital are automatically Class 3 and Class 4, because if they weren't shortness of breath at rest or shortness of breath with minimal exertion, they wouldn't be admitted to the hospital. The most common adverse effect is hyperkalemia and gynecomastia. Your anti-androgenic. Aldosterone antagonists are anti-androgenic. That's good if you're a woman suffering from hirsutism. That's not good if you're a man who does not want to wear a bra. Eplerenone is a medication that is just like spironolactone. It's an aldosterone antagonist. It lowers mortality in congestive heart failure. But eplerenone does not give you gynecomastia because it's not anti-androgenic. Okay, it's not anti-androgenic. You use spironolactone to lower mortality in congestive failure. It's a big deal. You go through and you say, hey, which of these drugs is most likely to benefit the patient? ACE and ARBs, beta blockers, and spironolactone. But when you have the anti-androgenic effects, you got to definitely switch to eplerenone. Diuretics have been a mainstay of fluid overload for the last 60 years, and it's going to stay so with acute pulmonary edema. Diuretics are the most useful in emergency management of acute pulmonary edema. Person comes with Ralls therapeses, jugular venous distension, acute shortness of breath, hyperventilation. Oxygen, a diuretic is first therapy. Oxygen, a diuretic. Now, we use them in combination with ACE and ARBs. We use them in combination with beta blockers, ACE and ARBs, in the routine management of outpatient congestive heart failure, as long as we understand that this is not doing them any benefit, except simply it's symptomatic control, and that's a pretty good thing to have symptomatic control. Furosemide, torsinide, bumetanide are all equal. They're all loop diuretics that make you lose a lot of volume. Spironolactone, again, although it's a diuretic, it's not used in a diuretic dose. Diuretics are for symptom control. Furosemide, torsemide, bumetanide are for symptom control. They don't lower mortality. Digoxin is to decrease symptoms. Digoxin, again, the single most frequently asked question is a person with congestive failure who started on digoxin, what is the major benefit? And the answer is decreasing symptoms, decreasing hospitalizations. but not decreasing mortality. Make sure you understand it. No positive inotrope, not digoxin, nor dobutamine, nor amrinone, nor milrinone, has ever been shown to lower mortality. They are symptom controlling drugs. That's it. Devices that lower mortality in congestive heart failure are basically two. One is to remember that since the most common cause of death is ischemia-mediated arrhythmia, well, if you're going to die from an arrhythmia, you put an implantable defibrillator, you can snatch them back from the jaws of death, and they won't die as much. That's a pretty cool thing. Then biventricular pacemaker. You see, you need the atrium and the ventricles. You need everything contracting in an organized, logical fashion. And if you have one side of the heart contracting out of sync with the other, if you have the left ventricle and the right ventricle not contracting in sync, if you have the right ventricle contracting too soon, or the other way around, you get an inefficient heart. However, biventricular pacemaker, to get the heart resynchronized, only works for a very narrow circumstance. And that narrow circumstance is a low ejection fraction and a wide QRS. That's it. So this is not for the general population of people with congestive failure. It's for this narrow population of low ejection fraction and wide QRS. Just remember, a biventricular pacemaker is not a dual chamber pacemaker. And like, what are you talking about? It says biventricular. Yeah, I understand how it can be confusing. See, the term dual chamber pacemaker means a pacemaker that's in the atrium, then the ventricle. And it goes in sequence, contracting first the atrium, then the ventricle. And that organizes the heart so it pumps in a logical fashion from atrium to ventricle to out, from atrium to ventricle to out. And biventricular pacemaker is not like that. It is to get both ventricles contracting at the same time. Patients can be very, very symptomatic and feel like they just got a cardiac transplant from a biventricular pacemaker. Dual chamber pacemaking has its place, but not particularly in congestive failure. Biventricular pacemaker resynchronizes that heart when there's a conduction delay. That conduction delay can make it so the heart really beats out of sync with the two ventricles, and it makes people quite short of breath, and the biventricular pacemaker fixes that on the spot. Gets rid of the need temporarily for cardiac transplant, and people can buy themselves a couple of extra years by having markedly improved symptoms. Now, it will not permanently eliminate the need for cardiac transplant, but it can put it off for a little while. Ultimately, if a person is on maximum medical therapy and they're on an ACE, a beta blocker, spironolactone, or a eplerenone, diuretics, digoxin, biventricular pacemaker, warfarin's not going to help, then ultimately, if you're still symptomatic, the only way to fix them is with the transplantation. But it has to be specifically for a person for whom we have tried maximum medical therapy, all the classes, and they are still symptomatic. In that case, transplantation. Let's make 100% sure that we get all of these questions right for such an indispensable subject as congestive failure. ACE inhibitors or angiotensin receptor blockers as afterload reduction. Beta blockers, metoprolol, carvedilol, bisoprolol, spironolactone, or eplerenone. All of these drugs will lower aldosterone. All of them improve mortality. Hydralazine and nitrates is not as good as an ACE inhibitor, not as good as an ARB. It's a third-line drug for people who just can't take ACE or ARB. Implantable defibrillators help, and they do decrease mortality. Calcium channel blockers do not lower mortality, and some people they actually can raise mortality. Now, I wish there were as clear a set of drugs that lowered mortality and diastolic dysfunction. I do, but there just aren't. When that ejection fraction is preserved, when it's diastolic dysfunction, sometimes hypertrophic cardiomyopathy, Although we may use beta blockers, it's just less clear what lowers mortality. It's just less clear. Beta blockers have benefit. We're not certain that they lower mortality all the way, but they're definitely beneficial. And it's been very hard to prove that any drug lowers mortality in diastolic dysfunction. Digoxin, however, we will not even use, since digoxin's main effect is to decrease symptoms of systolic dysfunction. There's zero indication for them in diastolic dysfunction. Zero. In hypertrophic cardiomyopathy, otherwise known as diastolic dysfunction, we can use diuretics to control symptoms of fluid overload because remember, it's not a hypertrophic obstructive cardiomyopathy. In a hypertrophic obstructive cardiomyopathy, diuretics would actually worsen the symptoms acutely because diuretics would make the chamber size smaller and increase the obstruction. But hypertrophic obstructive cardiomyopathy is a very rare entity. Almost all of it's just simple hypertrophic cardiomyopathy, which we can use to decrease the symptoms of fluid overload. And you don't have to worry about confusing this with hypertrophic obstructive cardiomyopathy, because in that disorder, we don't want to use diuretics, because anything that makes the chamber size smaller would worsen the obstruction. This section is indispensable to not just passing and excelling, but for all medical care. If you don't know the drugs that lower mortality in congestive failure, we are going to have a real problem here. Let's take care of humanity, and I'll see you in the next section.